This is a cardiovascular conference at the National Naval Medical Center. The way that these have been conducted in the past is that several specimens have been presented, and then the morphologic features have been discussed, and then the clinical story has been presented. The first specimen here today is a congenitally malformed heart, and there is transposition of the great arteries. That's the major malformation. Here is the aorta, and it arises directly anteriorly. It's the most anterior of the two vessels. And the pulmonary trunk is back here. This is the pulmonary trunk back here, and it arises posterior to the aorta, which is here. So obviously there is complete transposition of the great arteries. About over half of the patients with transposition, I used to think a lot more than that, have ventricular septal defects, but in this particular patient, the ventricular septum is entirely intact. There are no ventricular septal defects at all. A mustard operation has been performed. I'm not sure whether there was a ductus or an atrial septal defect prior to the mustard procedure. But at any rate, this is a heart in which a mustard operation has been performed. And we are looking at the specimen many months or several years after the procedure. And it's been unusual in my experience to have the opportunity to examine a heart late following a mustard procedure. So this is a very interesting specimen. So I think what we're dealing with here is complete transposition of the great vessels. And there's no ventricular septal defect. Whether there was an atrial septal defect, I'm not certain, and I doubt if there was a ductus. There's no ductus now. So the only possible communication here prior to operation was an atrial septal defect, if indeed that were the case. But as you know, in transposition, you're dealing with a situation where you have blood coming in to the vena cava, going to right atrium, then right ventricle, and out the aorta and back to vena cava. And on the other side, we have pulmonary veins going into left atrium, then into left ventricle, then into the pulmonary arteries and back into the pulmonary veins. So unless we have a communication at the ventricular level or a ductus or at the atrial level, we're dealing with entirely two separate setups. And I think the only possible communication here would have been at the atrial level. I just simply don't know that by examining this heart. Now what the mustard procedure that was done was that flow coming in from the vena cava, and that's inferior vena cava and superior vena cava, was directed over to the left atrium, and then from there into the left ventricle, and then out into the pulmonary trunk. So we're dealing with venous blood going into the lungs to get oxygenated. And then the pulmonary veins were altered so that rather than flowing into the right atrium, into the left atrium, they were altered so that they changed into the right atrium, and then there from right ventricle and then out aorta, and then back to vena cava. Now, if that's the situation, and I should mention there's no obstruction to outflow here of either RV or LV. There are no obstructions. There are no shunts. Why are we examining this heart at necropsy? Why did this patient die? Arrhythmias are a problem following a mustard procedure. Certainly I can't see that here. But I think the major problem here is that we did not get 100% of pulmonary veins switched. And that is, I think in this particular case, the right pulmonary veins were connected to right atrium, and then to right ventricle, and then going out aorta. But the left pulmonary veins, I believe, the left pulmonary vein still goes in to left atrium. So we're still dealing with a 50% shunt. That's how I interpret this situation at the moment. Now, if that interpretation is correct, why couldn't the pulmonary veins have been totally moved over to right atrium? This is a pulmonary, these are the pulmonary veins really from the right lung. They flow normally now into right, well, they don't flow normally, but they flow into right atrium, then into right ventricle, which is very thick-walled, and then out right ventricle into aorta. But the left pulmonary veins do not. Best I can tell here, the left pulmonary veins are still flowing in to the left atrium. And I think that is a major problem here. Another thing that is worthy of discussion, and that is, this is the anatomic left ventricle. This is the one that supplies the, gives rise to the pulmonary trunk. But look how thin that left ventricular wall is. It is really, really thin. In contrast, look how thick, right here, the right ventricular wall is. It's more than 2 times as thick as the left ventricular wall. Now, of course, the right ventricle has become the systemic ventricle. It's where the aorta arises. I'd like the incidental things here. The endocardium of the right ventricle, which is the systemic ventricle, has an opacity which the left ventricle does not. Now, I interpret this opacification in right ventricle as an anatomic indicator of probably inadequate perfusion. So that's an unusual situation to see the right ventricle being diffusely inadequately perfused and the left ventricle showing no sign of that. Obviously, they've switched the systemic and pulmonary responsibilities. What was the situation clinically here? I must say, from what I see, I think the major problem is the lack of switching of the drainage of the left lung into the right atrium. The right lung drains now physiologically. That is, it drains into a right atrium and via right ventricle out aorta. That's not the case with the left pulmonary veins. What's the story here?
This was a 4.5-year-old boy who was born with transposition of the great vessels and had a Rashkin procedure at age 24 hours. He still was symptomatic, and at age 6 weeks, it was followed up with a Blaylock-Hansen procedure.
Hanlock. Hanlon.
Hanlock.
Hanlon. Hanlon. Is that what you said?
Yeah.
So he had no communications at birth, is that right?
That's correct.
Between the two circuits, not at the atrial level, ventricular level we know, or at a ductus. That's correct. So we're dealing with two entirely separate circulations.
He had several interim admissions at hospitals in District of Columbia and Philadelphia for evaluations, and was scheduled actually 2 years ago for a mustard correction, but developed a Shigella infection, and his procedure was postponed. Finally, in February of 1974, he did undergo the mustard procedure at D.C. Children's Hospital, and the surgeons apparently felt they had a good fix at that time. 7 hours after the operation was completed, he suffered a cardiopulmonary arrest with apparently prolonged hypoxia, with a residual neurologic damage shown by a quadriplegia, incontinence of urine and feces, and what is referred to as mutism. He was hospitalized for several months and then was brought home. He was brought into Bethesda Navy Hospital in June of 1974 with pneumonia and responded to penicillin. Returned back home again. In early October, had symptoms of an upper respiratory infection and was treated with decongestants beginning 12 days prior to this final admission. 5 days prior to admission, he had x-ray indications of a pneumonia in the right lower lobe and the left upper lobe, and was started on penicillin as an outpatient. Then on the 15th of October was admitted for a pulmonary toilet and IV penicillin treatment. The first 4 days of his hospital stay, he did not have a fever, but did not really improve significantly. On the 19th of October, he developed a fever as high as 105. His white count went up to 13,000. He had an unrevealing septic workup, including lumbar puncture. Had vomited during the day, but had no x-ray evidence of aspiration. Then at 0100 on October 20th, suffered a cardiopulmonary arrest and did not respond to resuscitative measures. And at gross autopsy, apparently had a respiratory death. The etiology of the pneumonia is not yet known.
Did the surgeon believe that at the time of the mustard procedure that he indeed transferred properly the left pulmonary veins? Or it doesn't look like to me an attempt was made to do that.
Yeah, I did not speak to the surgeon myself, but the chief of anatomic did, and apparently they felt that they had.
Was he ever studied post-op?
No, there is no. I do not have a record of a study post-op. The last one I have is September of '73.
And why was it believed that did he ever have cardiovascular symptoms after the mustard procedure, or did he just die from progressive CNS situation?
Well, there's, I think the feeling was that the cardiac condition had improved and that his main problems were neurologic. His oxygen saturations improved, although I don't have specific figures. He just was not very active because of his depressed neurologic state, and it probably was not really taxed.
Did he? You mentioned quadriplegia. Or
yes.
Was he quadriplegic? I mean, that remained. That
remained until death. The only improvement that I could find in any of the chart notes was some movement at his left upper extremity.
Wow. Quadriplegia, man, I haven't heard of quadriplegia following a cardiac operation. Have you folks? Well, in mustard, you can generally get all 4 veins transferred, can you not?
described would lead to total resolution of the cyanosis. I assume that the systemic return was correct. The systemic venous return was such that there would no longer be systemic unsaturation. And so in looking at a patient with transposition whose predominant symptoms relate to the cyanosis, he would have expected to look like a good clinical result from the anatomical findings, but would still be left with some increased pulmonary flow, presumably from the nature of the failure to divert all the pulmonary venous return to the systemic circuit. And so I think that clinically he might have looked better than he was physiologically.
So he really never was up again. So whether or not he did have too much flow to his lungs, that was not his problem. He died from complications of the quadriplegia. Is that?
Well, it depends on what the etiology of his pneumonia was. He probably was more susceptible to aspirating, and he had vomited during that day. There was no X-ray evidence that aspiration had led to his pneumonia, but just following the sequence of events with him aspirating, and then later that day developing a high white count and increased respiratory difficulty, increased respiratory rate, you could say that the neurological condition maybe contributed to the final cause of his death.
I think this is an example of the tremendous progress made, though. Here we're dealing with a heart really with two separate circulations. He did not have a ASD because they did a Rashkin, right? I mean, that's probably a pretty good
Correct.
assumption. He certainly doesn't have a VSD, we can tell that now. He didn't have a ductus because they went back in and did they did a Blaylock-Hanlon. But there's no evidence of any ductus here at all. So they must have, so we must have had two entirely separate circulations, and yet this child lived 4.5 years. Technically, this looks potentially totally correctable. If they could have gotten those left pulmonary veins a little further over. Now, why could he have a stroke with quadriplegia? And he was mentally okay, huh? Was that an embolus?
No, he was described as mute. He would respond to his mother, and he was able to be fed by mouth by his parents. But beyond that, apparently there was not much neurologic function.
What kind of rhythm disturbances did he have after the mustard? That's a problem. Sometimes, I gather.
The actual summary at the time he was transferred to the hospital for sick children for his physical therapy states that he had multiple problems with arrhythmias, but the notes in the chart itself, the only actual mention of arrhythmias, and in fact it's not one, say that he has a tachycardia of 170 between the time of operation and the time of the arrest. Those are the only references to that subject. And I have no EKGs from that period.
Okay. Well, can we move on to the next case? Other comments or questions? Here is a heart with a very dilated LV cavity. Now, this has been bread loafed, so this is the LV cavity, and this is the RV sitting on top. Now, the RV is not dilated at all. The RV, can you see that? RV is not dilated at all. LV is considerably dilated. There is circumferential, at least subendocardial fibrosis, at least. It goes all the way around. In addition to that, there are many areas of transmural fibrosis, and there's a thrombus on top of it. And this goes all the way from the apex the apex of the heart. That's transmural scar with clot on top of it, all the way up to the base. Now, all the base is not involved, but much of it is. So this is about the largest infarct that one can have when you go all the way around. Circumferential, that's the biggest one can have. So if we look at that, at the base, it's anterior. Let's say this is anterior and this is posterior. Posterior begins about right here. That's about as much as fibrosis as he had, and superimposed on that was thrombus. Now, if we come across this way, RV is normal size. LV is very dilated, and everywhere there's subendocardial fibrosis, and in many areas there's transmural fibrosis. And now he obviously lived long enough to heal all this, but an LV cavity that dilated with superimposed thrombus on it, this is ischemic cardiomyopathy. I like that term. It was introduced by Dr. Birch in New Orleans. But I think the situation is that here these patients, just massive heart failure, look like cardiomyopathy of the ventricular dilated type, but it's due to coronary atherosclerosis. So I would suspect this fellow had massive heart failure. And most people who have severe heart failure following a myocardial infarction have had hypertension. If you eliminate valvular heart disease, hypertrophic cardiomyopathy as a cause of congestive heart failure, according to the Framingham study, 75% of people that have congestive heart failure have been hypertensive. So hypertension is a real important predisposer to congestive heart failure. So I would certainly think he had hypertension. How long this infarct had been there, certainly it's been several months, but I would think his problem was not chest pain after the initial myocardial infarction, but severe heart failure. I do think he had hypertension at one time, but I know that it's not possible to generate a hypertensive pressure with an LV like that. So I just know he did not have hypertension after his myocardial infarction. What's this number, 212?
Right.
What's the story on this patient? I'd say obviously he's a man, but this heart looks pretty young actually. The aorta looks young. There's not much atherosclerosis in the ascending aorta. It looks very good indeed. Hope mine looks like that good. But I'd say he's in his 40s. What's the story?
Well, this was a 39-year-old Caucasian male who was admitted here on the 1st of September of '74 for evaluation of anemia and leukopenia, strangely enough. He was also obviously status post anterior lateral massive myocardial infarction, documented in May 1974, and had been troubled with persistent arrhythmias. He was not.
Now that infarct was May
74.
And when did he die?
He died on 7 October 74.
October 74. So May, let's see, June, July, August, September, October, 5 months. He lived 5 months after the infarction, right?
Correct.
But he had the infarction before the anemia and leukopenia or afterwards?
He had the infarction prior to that. He was apparently in generally good health, except for his myocardial infarction at his admission in May. We have no record of his being hypertensive. This work was done in Georgia, and we don't have any chart from there.
Don't hold out against him. That's where I'm from.
His most immediate problem on admission here was that of uncontrolled cardiac arrhythmia and moderate congestive heart failure. He wasn't ever in really severe failure.
Is that right?
That's correct. Hematology was consulted to work up the anemia and leukopenia. And during the workup, they performed a bone marrow biopsy and found a poorly differentiated lymphoma, possibly of the Burkitt's type. Later, it was proved to be Burkitt's lymphoma. By this time, he had...
Some people are lucky, aren't they?
Yeah. By this time, they had arrived at fairly good control of his arrhythmias with a multiple antiarrhythmic drug regimen. He was given several courses of chemotherapy for the lymphoma and responded rapidly with a decrease in his peripheral white count from 44,000 to 7,000. He maintained a relatively stable course until 7 October, which was actually 2 months after admission. He then showed a course of ventricular fibrillation, which was unresponsive to multiple attempts at cardioversion, and he then expired on 7 October.
Well, I would venture to say that his lymphoma did not hasten his demise. But you say that he never was in severe heart failure during these last 5 months. Is that right?
That's correct.
That's not true.
That's the impression we got from the clinical summary.
Biopsy one morning for an X-ray finding and physical finding they thought were pneumocystis carni, and he was given vigorous Lasix therapy for a 2-day period, and his pneumocystis went away as his urine output increased. So I would think he was in frank congestive failure at that time.
He was never in severe congestive failure. I took care of this man for 2 months. It was very easy to push him into congestive failure with overloading him with fluids. And we had to do that because he went into ureatropathy and shut down his kidneys. But with careful attention to fluid balance and with diuresis, you could make this man really quite comfortable. He was hectic.
You better get the microphone.
This man was cachectic from the very day he arrived in this hospital, and for that reason he never did have any exercise tolerance. But at rest he was perfectly comfortable. He had no problem with shortness of breath, and during those most of the time when we had him in good fluid balance, he had no complaints of dyspnea, orthopnea, or PND. So at rest he was well compensated, but he really never did get any particular cardiovascular stress at all.
Did he sleep flat?
Yes, he did.
Slept flat in bed. With a heart like that, to the end, he slept flat in bed.
Even with the chest X-ray that showed interstitial edema, which responded to diuretics, he still slept fine.
Boy, now if he had severe failure of his right ventricle as well as his left, maybe he could slept all right in bed. But the right ventricle is normal size. But the left ventricle is just huge here, and this is circumferential infarction. And he slept flat in bed. And there was a debate how much heart failure he had at any rate.
The only time
it was
in
never 4 plus, never 16 plus.
In reading through the chart, the only documented times he was he had respiratory difficulty due to congestive failure was thought to be due to probable fluid overload at that time. But as the clinician noted, apparently at rest he was not in severe failure.
Now, what were his risk factors? Age 39, a myocardial infarction. Cholesterol was what?
Don't have the actual value. He was diagnosed as a type 4.
Oh, he was type 4.
Correct.
Well, that's good information. No question that hyperlipoproteinemia accelerates atherosclerosis. His weight was less than normal, right? Not a diabetic. And nobody knows as far as anybody knows, he was not hypertensive at any time. 39 years old. Now, he never had angina, right? He never had chest pain after the myocardial infarction. Well, that fits. At least it's very unusual to have chest pain when you have an LV like that. Very unusual. Another thing interesting about this, if you look at this slice, for example, the echocardiogram, let's say, would come right through here. Okay. Look how thick the septum is. How thick the septum is compared to the posterior free wall right here. I mean, certainly that's more than a 1.3 ratio. Now, he's had subendocardial necrosis with fibrosis of posterior wall, but his septum up here has not been involved. So that's acquired ASH. Acquired ASH following myocardial infarction. ASH secondary to myocardial infarction. Well, that'd sell, wouldn't it?
I can make that diagnosis by echo.
Well,
Poor posterior wall movement.
well, if you just stick with with that ratio, I think one's going to get burned periodically. That's the point of that. Okay, 39-year-old. Boy, I'll tell you, I hope that's the last myocardial infarction in a 39-year-old I ever see. I'm glad I'm too old for that. Past that risky period. Now, can you see that? Now, this is cardiomyopathy. Here we have ventricular septum, LV free wall, RV free wall, thrombus in the apex of RV, thrombus in apex of LV. Classic cardiomyopathy. The valves are normal, and the coronary arteries, I've seen this specimen before, are normal. There's no obvious foci of fibrosis or necrosis. Another thing to note is the mitral annulus. See, the mitral annulus is relatively small. The biggest dilatation is about midway down. It's much bigger here than it is up here. Much bigger. Annular dilatation, in other words, is not the cause of mitral regurgitation in cardiomyopathy. Classic cardiomyopathy. Clots and LV, RV, no necrosis, no fibrosis, valves normal, coronaries clean. But this is a child. This is not an adult heart. That's a baby's heart. I mean, not a baby, but that's baby fat or teenage fat. I know that this is a teenager, but that's classic. If you look even here at this one, look at the septum right there, close to the aortic valve. It's much thinner than it is down here. See that? Thinner up there than it is down here. Okay, what's the story here?
This was a 10-year-old Caucasian female from Roosevelt Roads, Puerto Rico hospital, who was apparently well until early September '74 when she had the onset of nausea and vomiting, followed by increasing peripheral edema. This was about a 2-week history of nausea and vomiting. Terminated with, well, she had multiple visits to the clinic there, and finally she was admitted when they noticed that she had increasing peripheral edema. She was then transferred to National Naval Medical Center on 15 September with physical findings of congestive heart failure, probably secondary to a myocarditis. They thought it was probably viral etiology. Her symptoms initially responded very poorly to digoxin and diuresis. Her white counts were ranging between 8 and 15,000 with slight left shift. Her platelets were consistently decreased to counts between 65 and 80,000. Her ASO titers were consistently less than 200 Todd units. Viral titers were normal, both acute and convalescent. Eventually, during her third hospital week, she developed a morbilliform rash over the chest, back, and abdomen. She subsequently developed acute abdominal pain, restlessness, and chest pain. She then had a cardiac arrest and was successfully resuscitated twice. Finally, several hours later, her cardiac electrical activity deteriorated and she was not responsive to epinephrine, calcium chloride, atropine, or sodium bicarbonate. She expired on 7 October, approximately 1 month after admission. She was on prednisone during her hospitalization for approximately 2 weeks, I believe, and then was tapered off. She did not respond to this either. Post-mortem findings.
So, wait a minute. Her total length of illness was how long?
We have early September until early October.
So, 1 month.
Approximately, yes.
So 1 month of a cardiomyopathy is a very short course. Go ahead.
All right, at autopsy, the most significant findings obviously were the massive dilatation of both ventricles of the heart and some congestive findings. Other than that, it really was a normal autopsy until the histology came back and we found findings of either Cryptococcus or perhaps North American blastomycosis throughout the
She's
lungs.
From Puerto Rico.
Correct.
Puerto Rico is North America, right?
Depends on where you live.
Huh? Okay. Fungus. Fungus was where?
Throughout both lungs, throughout lymph nodes in the thorax and abdomen, and the mesenteric lymph nodes. They may also be in the brain. We haven't cut that yet. We don't know.
Well,
Fungal titers were not done pre-mortem.
were there a lot of organisms?
Yes. A remarkable replacement of lymph node architecture with it, as well as lungs.
Is that right?
Mm-hmm.
Boy, I don't see any lesions here in myocardium in retrospect. I can't see how fungus would do this. I mean, the fungus came on before the prednisone, or the prednisone must have come on before the fungus.
That's going to be impossible for me to tell. We have no serum from her prior to her prednisone therapy, but the findings of abdominal pain, nausea, and vomiting, etc., were what her original complaint was 2 weeks prior to her admission, and then this is what she terminally had. I don't know whether this can be related or not.
What did the electrocardiogram show? You know that?
Let's see if I have it written down here. I think it's on that sheet I gave you.
But this on X-ray was a big heart,
Yes.
and clinically this was called cardiomyopathy. And the unusual feature clinically was what?
The unusual feature?
Yeah.
Well, at first she seemed to be responding, although she had been, quote, not responsive to diuretics. She had not gotten much in the way of diuretics. She was transferred here, and with more vigorous diuresis, she initially responded well.
Right.
And it looked like she was going to be turning the corner. And then she just became less and less responsive, more and more congested. She had had a low-grade fever. There was some fear that she might have had an endocarditis type of picture, or perhaps rheumatic fever. And so she got penicillin and steroids and kind of a shotgun therapy, trying to, ditch diuretics, steroids, and antibiotics, but just became refractory to all therapy and just rapidly went downhill.
But I think the most unusual thing about her course for cardiomyopathy you've already alluded to, and that's the very rapid progression and probably her age. We know that if we admit a patient with congestive heart failure from most any etiology, and the cardiomyopathies in that category, that they will usually improve with bed rest, and that you will have more admissions, that the patient will respond initially, And while the heart size may not get much smaller or return to normal, you expect that the initial clinical response is going to be good in those patients, primarily because they haven't had medication and the progress of the disease isn't that fast. But in her, she was quite different. She got a very brief initial diuresis, perhaps, but beyond that, her course was rapidly progressive on bed rest and all the medication that she could be given. And I'm not sure whether that favors myocarditis over myocardiopathy. I think that it favors a very rapidly progressing problem in the heart, and we thought that she might have myocarditis.
So clinically, it was intractable heart failure.
Yes, but she did not have AV conduction problems, as I recall, ectopic rhythm disturbance, or electrocardiographic features of myocarditis. I don't think those circumstances were there.
Did she have LVH? Do you remember?
There was a progression of her voltage during this a rather brief time, as I recall, in the left ventricular voltage on our tracing. I believe that was all.
What about at necropsy? Did you see inflammatory cells in histologic sections of myocardium or not?
They haven't been evaluated yet.
Oh, I see. Well, I'll bet that despite this short course, that this will not be myocarditis. Meaning no inflammatory cells in myocardium. But I guess, what about the possibility of Chagas disease? Puerto Rico? Chagas does it occur there?
The possibility was considered, and yes, it does occur sporadically in Puerto Rico.
The one thing about Chagas from a heart standpoint is that Chagas causes really spectacular thinning of myocardial walls right at the apices of both right and left ventricle. And this has been described, but there was a fellow with me a few years ago who brought some specimens from Brasilia. And these things at the wall here would just be paper thin. But there are a few patients that died during the acute Chagas initial illness, isn't that right?
Yes. The electrocardiogram in Chagas disease is that of first-degree AV block, left axis deviation, right bundle branch block. In other words, it's trifascicular block that you see often associated with even a second-degree AV block. And so her electrocardiogram didn't look like Chagas. And whether the patients that die of acute Chagas disease die of congestive heart failure, or whether they die suddenly from rhythm disturbance and are found at postmortem examination to have Chagas disease, I don't know.
Well, those are three spectacular cases. Here we have complete transposition 4.5 years later, 2 separate circulations. And the circulations were made non-separate by Rashkin, unsuccessful, taking out the atrial septum, and finally complete correction, quote, complete correction. 39-year-old man with acute myocardial infarction, circumferential at least in the lower 2/3 of the LV, and yet what I would call ischemic cardiomyopathy by looking at the specimen, but yet he slept flat in bed and not a great deal of heart failure. And third, 10-year-old child with 1-month course of heart failure. That's a pretty good afternoon. Thank you. Okay.
Do you know what the histological sections on the heart on the second page showed? Is that tumor in there?
Man.